Discuss the topic of chronic inflammation, and we will start from the definition. Inflammation is a response of a prolonged duration in which inflammation, tissue injury, and attempts at repair coexist in varying combinations. Chronic inflammation may follow acute inflammation or may begin insidiously as a smoldering, sometimes progressive, process without any signs of a preceding acute reaction. Chronic inflammation arises in persistent infections and prolonged exposure to potentially toxic agents, either exogenous or endogenous. Some forms of chronic inflammation in cases of neurodegenerative diseases such as Alzheimer's disease, metabolic syndrome, and the associated type 2 diabetes and certain cancers may lead and promote tumor development. Persistent infections by microorganisms that are difficult to eradicate, such as mycobacteria and certain viruses, fungi, and parasites. These organisms often evoke an immune reaction called delayed type hypersensitivity. The inflammatory response sometimes takes a specific pattern called granulomatous inflammation. In other cases, unresolved acute inflammation evolves into chronic inflammation, such as when an acute bacterial infection of the lung progresses to a chronic lung abscess. Chronic inflammation plays an important role in a group of diseases that are caused by excessive and inappropriate activation of the immune system. In autoimmune diseases, self-antigens evoke a self-perpetuating immune reaction that results in chronic inflammation and tissue damage. Examples of such diseases are rheumatoid arthritis and multiple sclerosis. In allergic diseases, chronic inflammation is the result of excessive immune responses against common environmental substances, as in bronchial asthma. Because these autoimmune and allergic reactions are triggered against antigens that are normally harmless, the reactions serve no useful purpose and only cause disease. Such diseases may show morphologic patterns of mixed acute and chronic inflammation because they are characterized by repeated bouts of inflammation. Fibrosis may dominate the late stages. Prolonged exposure to potentially toxic agents, either exogenous or endogenous, was mentioned earlier. An example of an exogenous agent is particulate silica, a non-degradable inanimate material that, when inhaled for prolonged periods, results in an inflammatory lung disease called silicosis. Atherosclerosis is a chronic inflammatory process affecting the arterial wall that is thought to be induced, at least in part, by excessive production and tissue deposition of endogenous cholesterol and other lipids. Some forms of chronic inflammation may be important in the pathogenesis of diseases that are not conventionally thought of as inflammatory disorders. These include neurodegenerative diseases such as Alzheimer's disease, metabolic syndrome, and the associated type 2 diabetes, and certain cancers in which inflammatory reactions promote tumor development. The role of inflammation in these conditions is discussed in the relevant chapters and later on in the course of this in this course. In contrast to acute inflammation, which is manifested by vascular changes edema, and predominantly neutrophilic infiltration, chronic inflammation is characterized by the following: infiltration with mononuclear cells, which include macrophages, lymphocytes, and plasma cells; tissue destruction induced by the persistent offending agent or by the inflammatory cells; attempts at healing by connective tissue replacement of damaged tissue accomplished by angiogenesis, a proliferation of small blood vessels, and in particular fibrosis. The combination of leukocyte infiltration, tissue damage, and fibrosis that characterize chronic inflammation is the result of the local activation of several cell types and the production of mediators, including macrophages, lymphocytes, and other cells, including eosinophils and mast cells. The dominant cells in most chronic inflammatory reactions are macrophages, which contribute to the reaction by secreting cytokines and growth factors that act on various cells by destroying foreign invaders in tissues and by activating other cells, notably T lymphocytes. Macrophages are professional phagocytes that act as filters for particulate matter, microbes, and senescent cells. They also function as effector cells that eliminate microbes in cellular and humoral immune responses, but they serve many other roles in inflammation and repair. Macrophages are tissue cells derived from hematopoietic stem cells in the bone marrow, shown by red arrows, and from progenitors in the embryonic yolk sac and fetal liver during early development. Circulating cells of this lineage are known as monocytes. Macrophages are normally diffusely scattered in most connective tissues. In addition, they are found in special locations in organs shown by the green arrow, such as the liver, where they are called Kupffer cells, spleen and lymph nodes, where they are known as histiocytes, central nervous system, where they are known as microglial cells, and lungs, alveolar macrophages. Together, the cells comprise the mononuclear phagocyte system, also known by the older and inaccurate name of reticular endothelial system. In inflammatory reactions, progenitors in the bone marrow give rise to monocytes, shown by the red arrow, which enter the blood, migrate into various tissues, and differentiate into macrophages. Entry of blood monocytes into tissues is governed by the same factors that are involved in neutrophil immigration, such as adhesion molecules and chemokines. The half-life of blood monocyte is about 1 day, whereas the lifespan of tissue macrophages is several months or years. Therefore, macrophages often become the dominant cell population in inflammatory reactions within 48 hours of onset. The macrophages that reside in tissues in the steady state in the absence of tissue injury or inflammation, such as microglia, Kupffer cells, and alveolar macrophages, arise from the yolk sac or fetal liver very early in embryogenesis. They populate the tissues, stay for long periods, and are replenished mainly by the proliferation of resident cells. There are two major pathways of macrophage activation called classical and alternative. Which of these two pathways is taken by a given macrophage depends on the nature of the activating signal. Classical macrophage activation may be induced by Microbial products such as endotoxin, which engage toll-like receptors and other sensors, and by T cell derived signals, importantly the cytokine IFN gamma in immune response, interferon gamma. Classically activated macrophages produce nitric oxide and reactive oxygen species and upregulate lysosomal enzymes, all of which enhance their ability to kill ingested organisms and secrete cytokines that stimulate inflammation. These macrophages are important in host defense against microbes and in many inflammatory reactions. Alternative macrophage activation is induced by cytokines other than interferon gamma, such as interleukin-4 and interleukin-13 produced by T lymphocytes and other cells. These macrophages are not actively microbicidal. Instead, the principal function of alternatively activated macrophages is in tissue repair. They secrete growth factors that promote angiogenesis, activate fibroblasts, and stimulate collagen synthesis. The products of activated macrophages eliminate injurious agents such as microbes and initiate the process of repair, but are also responsible for much of the tissue injury in chronic inflammation. Several functions of macrophages are central to the development and persistence of chronic inflammation and the accompanying tissue injury. Macrophages secrete mediators of inflammation, such as cytokines, tumor necrosis factor, interleukin-1, chemokines, and others, and eicosanoids. Therefore, macrophages are central to the initiation and propagation of inflammatory reactions. Macrophages display antigens to T lymphocytes and respond to signals from T cells, therefore setting up a feedback loop that is essential for defense against many microbes by cell-mediated immune response. Macrophages' impressive arsenal of mediators makes them powerful allies in the body's defense against unwanted invaders, but the same weaponry can also induce considerable tissue destruction when macrophages are inappropriately or excessively activated. It is because of these activities of macrophages that tissue destruction is one of the hallmarks of chronic inflammation. In some instances, if the irritant is eliminated, macrophages eventually disappear, either dying off or making their way via lymphatics into lymph nodes. In others, macrophage accumulation persists as a result of continuous recruitment from the circulation and local proliferation at the site of inflammation. Microbes and other environmental antigens activate T and B lymphocytes, which amplify and propagate chronic inflammation. Although the major function of these lymphocytes is as the mediators of adaptive immunity, which provides defense against infectious pathogens, these cells are often present in chronic inflammation, and when they are activated, the inflammation tends to be persistent and severe. Some of the strongest chronic inflammatory reactions, such as granulomatous inflammation, are dependent on lymphocyte responses. Lymphocytes may be the dominant population in the chronic inflammation seen in autoimmune and other hypersensitivity diseases. By virtue of their ability to secrete cytokines, CD4 plus T lymphocytes promote inflammation and influence the nature of the inflammatory reaction. These T cells greatly amplify the early inflammatory reaction that is induced by recognition of microbes and dead cells as part of the innate immune response. There are three subsets of CD4+ T cells that secrete different cytokines and elicit different types of inflammation. Th1 cells produce the cytokine interferon gamma, which activates macrophages by the classical pathway. Th2 cells secrete interleukin 4, interleukin 5, and interleukin 13, which recruit and activate eosinophils and are responsible for the alternative pathway of macrophage activation. Th17 cells secrete interleukin 17 and other cytokines, which induce the secretion of chemokines responsible for recruiting neutrophils into the reaction. Both Th1 and Th17 cells are involved in defense against many types of bacteria and viruses and in autoimmune diseases. Th2 cells are important in defense against helminthic parasites and in allergic inflammation. Lymphocytes and macrophages interact in a bidirectional way, and these interactions play an important role in propagating chronic inflammation. Macrophages display antigens to T cells, express membrane molecules called co-stimulators that activate T cells, and produce cytokines, including interleukin 12 and others, that also stimulate T cell responses. Activated T lymphocytes in turn produce cytokines which recruit and activate macrophages, promoting more antigen presentation and cytokine secretion. The result is a cycle of cellular reactions that fuel and sustain chronic inflammation. Activated B lymphocytes and antibody-producing plasma cells are often present at sites of chronic inflammation. The antibodies may be specific for persistent foreign or cell antigens in the inflammatory site or against altered tissue components. However, the specificity and even the importance of antibodies in most chronic inflammatory disorders are still unclear. In some chronic inflammatory reactions, the accumulated lymphocytes, antigen-presenting cells, and plasma cells cluster together to form lymphoid structures resembling the follicles shown on the left picture found in lymph nodes. These are called tertiary lymphoid organs. This type of lymphoid organogenesis is often seen in the synovium of patients with long-standing rheumatoid arthritis, in the thyroid, in Hashimoto thyroiditis on the right picture, and the gastric mucosa in the setting of Helicobacter pylori infection. It has been postulated that the local formation of lymphoid organs may perpetrate the immune reaction, but the significance of these structures is not established. Other cell types may be prominent in chronic inflammation induced by particular stimuli. Eosinophils are abundant in immune reactions mediated by immunoglobulin E and in parasitic infections. Their recruitment is driven by adhesion molecules similar to those used by neutrophils and by specific chemokines like eotaxin derived from leukocytes and epithelial cells. Eosinophils have granules that contain major basic protein a highly cationic protein that is toxic to parasites but also injures host epithelial cells. This is why eosinophils are of benefit in controlling parasitic infections, yet also contribute to tissue damage in immune reactions such as allergies. Mast cells are widely distributed in connective tissues and participate in both acute and chronic inflammatory reactions. Mast cells arise from precursors in the bone marrow. They have many similarities with circulating basophils, but they do not arise from basophils. They are tissue resident and therefore play more significant roles in inflammatory reactions in tissues than basophils do. Mast cells and basophils express on their surface the receptor Fc epsilon Ri, which binds the Fc portion of immunoglobulin E antibody. And in immediate hypersensitivity reactions, immunoglobulin E bound to the mast cells Fc receptors specifically recognizes antigen, and in response the cell degranulates and release mediators such as histamine and prostaglandins. This type of response occurs during allergic reactions to foods, insect venom, or drugs, sometimes with catastrophic results leading to anaphylactic shock. Mast cells also are present in chronic inflammatory reactions, and because they secrete a plethora of cytokines, they can promote inflammatory reactions. Although neutrophils are characteristic of acute inflammation, many forms of chronic inflammation lasting for months continue to show large numbers of neutrophils induced either by persistent microbes or by cytokines and other mediators produced by activated macrophages and T lymphocytes. In chronic bacterial infection of bone, osteomyelitis, shown on the picture, and you can see the accumulation of neutrophils shown by the arrow and bone resorption shown by the star. In these cases of osteomyelitis, a neutrophilic exudate can persist for many months. Neutrophils also are important in the chronic damage induced in lungs by smoking and other irritant stimuli. This pattern of inflammation has been called acute or chronic. Granulomatous inflammation is a form of chronic inflammation characterized by collections of activated macrophages, often with T lymphocytes and sometimes associated with central necrosis. The activated macrophages may develop abundant cytoplasm and begin to resemble epithelial cells and are called epithelioid cells. Some activated macrophages may fuse, forming multinucleate giant cells shown by black arrows. Granuloma formation is a cellular attempt to contain an offending agent that is difficult to eradicate. In this attempt, there is often strong activation of T lymphocytes, leading to macrophage activation, which can cause injury to normal tissues. There are two types of granulomas, which differ in their pathogenesis: immune granulomas and foreign body granulomas. Immune granulomas are caused by a variety of agents that are capable of inducing a persistent T-cell mediated immune response. This type of immune response produces granulomas usually when the inciting agent cannot be readily eliminated, such as a persistent microbe or a self-antigen. In such responses, macrophages activate T cell to produce cytokines such as interleukin 2, which activates other T cells, perpetuating the response of interferon gamma, which activates the macrophages. On the picture, you see a granuloma on a liver biopsy. Granulomatous tissue carries a broad differential diagnosis. You should consider sarcoidosis, primary biliary cirrhosis, drug effect, tuberculosis if you see necrotizing, and schistosomiasis. Furthermore, it could be idiopathic and completely benign. That would be a diagnosis of exclusion. Notice in the histologic specimen above the well-circumscribed collection of cellular debris containing some inflammatory cells, including neutrophils that are multi-lobed cells, bile ducts, necrotic tissue, and extracellular matrix. Foreign body granulomas are seen in response to relatively inert foreign bodies in the absence of T-cell mediated immune responses. Typically, foreign body granulomas form around materials such as talc associated with intravenous drug abuse. Sutures on the left picture shown by the arrow, or other fibers that are large enough to preclude phagocytosis by a macrophage but are not immunogenic. Epithelioid cells and giant cells are opposed to the surface of the foreign body. The foreign material can usually be identified in the center of the granuloma, particularly if viewed by polarized light, shown on the picture on the right, in which it may appear refractile. In the usual H&D stained tissue samples, the activated macrophages in granulomas have pink granular cytoplasm with indistinct cell boundaries, and these are known as epithelioid cells, shown by red arrows. A collar of lymphocytes, shown by yellow arrows, surrounds the aggregates of epithelioids macrophages. Older granulomas may have a rim of fibroblasts and connective tissues. Frequently, but not invariably, multinucleated giant cells, shown by black arrow, 40 to 50 nanometers in diameter, are found in granulomas, and these are called Langerhans giant cells. They consist of a large mass of cytoplasm and many nuclei. Granulomas associated with certain infectious organisms, classically Mycobacterium tuberculosis, often contain a central zone of necrosis. Grossly, this has a granular, cheesy appearance and is therefore called caseous necrosis. On the left picture, you see a gross appearance of a lung with tuberculosis. Scattered tan granulomas are present, mostly in the upper lung fields. Granulomatous tissue, granulomatous disease of the lung, grossly appears as irregularly sized, rounded nodules that are firm and tan. Larger nodules may have central necrosis known as caseation, shown on the right picture. Microscopically, this necrotic material appears as amorphous, structureless, eosinophilic granular debris with loss of cellular details. The granulomas in Crohn's disease, on the left picture in the intestine, sarcoidosis on the right picture in the lung, and foreign body reactions tend to not have necrotic centers and are said to be non-caseating. Healing of granulomas is accompanied by fibrosis that may be extensive. Chronic inflammation is a prolonged host response to persistent stimuli that may follow unresolved acute inflammation or be chronic from the outset. It is caused by microbes that resist elimination, immune responses against self and environmental antigens, and some toxic substances. It underlies many medically important diseases. Chronic inflammation is characterized by coexisting inflammation, tissue injury, attempted repair by scarring, and immune response. The cellular infiltrate consists of macrophages, lymphocytes, plasma cells, and other leukocytes. It is mediated by cytokines produced by macrophages and lymphocytes, notably T lymphocytes. Bidirectional interactions between these cells tend to amplify and prolong the inflammatory reaction. Granulomatous inflammation is a morphologically specific pattern of chronic inflammation induced by T cells and macrophage activation in response to an agent that is resistant to eradication. Inflammation, even if it is localized, is associated with cytokine-induced systemic reactions that are collectively called the acute phase response. Anyone who has suffered through a severe bout of bacterial or viral illness like pneumonia or influenza has experienced the systemic manifestations of acute inflammation. These changes are reactions to cytokines whose production is stimulated by bacterial products such as LPS, viral double-stranded RNA, and by other inflammatory stimuli. The cytokines like tumor necrosis factor, interleukin-1 and interleukin-6 are important mediators of the acute phase reaction. Other cytokines, notably type 1 interferons, also contribute to the reaction. The acute phase response consists of several clinical and pathological changes: fever, acute phase proteins, leukocytosis, increased heart rate and blood pressure, decreased sweating, etc. Fever, characterized by an elevation of body temperature, usually by 1 to 4 degrees, is one of the most prominent manifestations of the acute phase response, especially when inflammation is associated with infection. Substances that induce fever are called pyrogens. The increase in body temperature is caused by prostaglandins that are produced in the vascular and perivascular cells of the hypothalamus. Bacterial products such as LPS, called exogenous pyrogens, stimulate leukocytes to release cytokines such as interleukin-1 and tumor necrosis factor, called endogenous pyrogens, that increase the enzymes that convert arachidonic acid into prostaglandins. In the hypothalamus, the prostaglandins, especially PGE2, stimulate the production of neurotransmitters that reset the temperature set points at a higher level. NSAIDs, including aspirin, reduce fever by inhibiting prostaglandin synthesis. How and even if fever contributes to the protective host response remains unclear. Acute phase proteins are plasma proteins, mostly synthesized in the liver, whose plasma concentrations may increase several hundred-folds as part of the response to inflammatory stimuli. Three of the best known of these proteins are C-reactive protein, CPR, fibrinogen, and serum amyloid A, SAA protein. Synthesis of these molecules in hepatocytes is stimulated by cytokines. Many acute phase proteins, such as C-reactive protein and serum amyloid A protein, bind to microbial cell walls, and they may act as opsonins and fixed complement. Fibrinogen binds to red cells and causes them to form stacks, rouleaux, that sediment more rapidly at unit gravity than do individual red cells. This is the basis for measuring the erythrocyte sedimentation rate as a simple test for an inflammatory response caused by any stimulus. Acute phase proteins have beneficial effects during acute inflammation, but prolonged production of these proteins, especially serum amyloid A protein in states of chronic inflammation, can in some cases cause secondary amyloidosis. Elevated serum levels of C-reactive protein serve as a marker for increased risk of myocardial infarction in patients with coronary artery disease. It is postulated that inflammation involving atherosclerotic plaques in the coronary arteries predisposes to thrombosis and subsequent infarction. Another peptide whose production is increased in the acute phase response is the iron-regulating peptide hepcidin. Chronically elevated plasma concentration of hepcidin reduce the availability of iron and are responsible for the anemia associated with chronic inflammation. Leukocytosis is a common feature of inflammatory reactions, especially those induced by bacterial infections. The leukocyte count usually climbs to 15,000 or 20,000 cells that normally normal ranges vary somewhat from lab to lab, but sometimes it may reach extraordinarily high levels of 40,000 to 100,000. These extreme elevations are referred to as leukemoid reactions because they are similar to and must be distinguished from the white cell counts observed in leukemia. The leukocytosis occurs initially because of accelerated release of cells from the bone marrow post-mitotic reserve pool, and this is caused by cytokines including tumor necrosis factor and interleukin-1. The leukocytosis is therefore associated with a rise in the number of more immature neutrophils in the blood, referred to as a shift to the left. Prolonged infection also induces proliferation of precursors in the bone marrow, caused by increased production of colony-stimulating factors. Therefore, if inflammation is sustained, the bone marrow output of leukocytes increases, an effect that usually more than compensates for the loss of these cells in the inflammatory reaction. Most bacterial infections induce an increase in the blood neutrophil count, called neutrophilia. Viral infections, such as infectious mononucleosis, mumps, and German measles, cause an absolute increase in the number of lymphocytes. In some allergies and parasitic infections, there is an increase in the number of blood eosinophils, creating an eosinophilia. Certain infections, like typhoid fever and the infections caused by some viruses, rickettsia, and certain protozoa, are associated with the decreased numbers of circulating white cells, and this process is known as leukopenia. In several bacterial infections, the large amounts of bacteria and their products in the blood stimulate the production of enormous quantities of several cytokines, notably tumor necrosis factor and interleukin-1. High blood levels of cytokines cause widespread clinical and pathologic abnormalities such as disseminated intravascular coagulation, hypotensive shock, and metabolic disturbances including insulin resistance and hyperglycemia. This clinical triad is known as septic shock. A syndrome similar to septic shock may occur as a complication of non-infectious disorders such as severe burns, trauma, pancreatitis, and other serious conditions. Collectively, these reactions are known as systemic inflammatory response syndrome. We discussed the systemic effects of inflammation, and it was mentioned the importance of fever that is a product of cytokine stimulation in hypothalamus, production of acute phase proteins including C-reactive protein and others, synthesis stimulated by cytokines acting on liver cells. We talked about leukocytosis when cytokines stimulate production of leukocytes from precursors in the bone marrow. In more severe infections, septic shock happens. The fall in blood pressure, disseminated intravascular coagulation, metabolic abnormalities, and induced by high level of tumor necrosis factor and other cytokines. There are several examples of chronic inflammation: chronic pancreatitis, chronic bronchitis, chronic pneumonia, chronic nephritis, and chronic myocarditis. Chronic pancreatitis is commonly defined as a continuous chronic fibroinflammatory process of the pancreas, characterized by reversible morphologic changes. Chronic pancreatitis is characterized by progressive inflammation and fibrosis of pancreas leading to irreversible damage. Fibrosis during chronic pancreatitis ultimately leads to progressive loss of the lobular morphology and structure of the pancreas, deformation of the large ducts, and severe changes in the disposition and composition of the islets. The chronic pancreatitis is a progressive inflammatory process leading to permanent histological irregularity and functional impairment. The etiological risk factors associated with chronic pancreatitis are multiple and involve both genetic and environmental factors. Numerous etiological factors have been identified: alcohol, smoking, genetic or hereditary, efferent duct obstructive systemic disease, autoimmune, and idiopathic. Although diverse risk factors can cause chronic pancreatitis, alcohol abuse is the major cause in the Western population, constituting up to 90% of the cases. Other than alcohol abuse, other toxic insults such as nicotine use and certain drugs can be associated with chronic pancreatitis. Chronic pancreatitis is characterized by parenchymal fibrosis, reduced number and size of acini, and variable dilation of the pancreatic ducts. There is a relative sparing of the islets of Langerhans initially. Acinar loss is a constant feature, usually with a chronic inflammatory infiltrate around remaining lobules and ducts. The ductal epithelium may be atrophied or hyperplastic or exhibit squamous metaplasia, and ductal concretion may be noted. The remaining islets of Langerhans become embedded in the sclerotic tissue and may fuse and appear enlarged. Eventually, they also disappear. On gross evaluation, the gland is hot, sometimes with extremely dilated ducts and visible calcified concretions. On the left picture, you see extensive fibrosis and atrophy that have left only residual islets, shown by red arrow, and ducts, shown by yellow arrows, with a sprinkling of chronic inflammatory cells and acinar tissue. On the right picture, you see a higher power view demonstrating dilated ducts, shown by the black arrow, with inspissated eosinophilic concretions, shown by the star, in a patient with alcoholic chronic pancreatitis. The diagnosis of chronic pancreatitis can be made based on typical symptoms and imaging studies that show damage and scarring of the pancreas. The following tests are required. The blood test to check for high level of pancreatic enzymes, amylase and lipase. A computed tomography scan, a magnetic resonance imaging, or ultrasound to detect inflammation and scarring of the pancreas. An endoscopic retrograde cholangiopancreatography, in which to look for blockages or damages to the ducts. A magnetic resonance cholangiopancreatography, which evaluates the ducts without requiring an endoscope or contrast material. Chronic pancreatitis manifests as repeated bouts of jaundice, vague indigestion, or persistent or recurrent abdominal and back pain, or it may be entirely silent until pancreatic insufficiency and diabetes mellitus develops. The later is a consequence of islet destruction. Attacks can be precipitated by alcohol abuse, overeating, which increases demand on pancreatic secretions, or opiates or other drugs that increase the muscle tone of the sphincter of Oddi. The diagnosis of chronic pancreatitis requires a high degree of clinical suspicion. During an attack of abdominal pain, there may be mild fever and modest elevations of serum amylase. In end-stage disease, however, acinar destruction may be so advanced that enzyme elevations are absent. Gallstone-induced obstruction may manifest as jaundice or elevated levels of serum alkaline phosphatase. A very helpful finding is visualization of calcifications within the pancreas by computed tomography or ultrasonography. Weight loss and hypoalbuminic edema from malabsorption caused by pancreatic exocrine insufficiency can also point to the disease. Although chronic pancreatitis is usually not acutely life-threatening, a 50% mortality rate is over 20 to 25 years. The most common long-term sequence of chronic pancreatitis is insufficiency of pancreatic exocrine enzymes with consequent malabsorption and deficiency of fat-soluble vitamins. Exocrine insufficiency typically predates endocrine dysfunction, and patients with severe loss of islets can develop diabetes mellitus. In other patients, severe chronic pain may dominate the clinical picture. Pancreatic pseudocysts developed in about 10% of patients. The most feared long-term complication of chronic pancreatitis is pancreatic cancer. The risk for malignant transformation in adult-onset disease is modest, with no more than 5% of patients developing cancer at 20 years. Chronic bronchitis is diagnosed on clinical grounds. It is defined by the presence of a persistent productive cough for at least several months in at least 3 consecutive years. It is common among cigarette smokers and urban dwellers in smoke-ridden cities. Some studies indicate that 20 to 25% of men in their 40 to 65-year-old age group have this disease. In early stages of the disease, the cough raises mucoid sputum, but airflow is not obstructed. Some patients with chronic bronchitis have evidence of hyperresponsive airways with intermittent bronchospasm and wheezing, known as asthmatic bronchitis, while other bronchitic patients, especially heavy smokers, develop chronic outflow obstruction, usually with associated emphysema. The distinctive feature of chronic bronchitis is hypersecretion of mucus, beginning in the large airways. Although the most important cause is cigarette smoking, other air pollutants such as sulfur dioxide and nitrogen dioxide may contribute. These environmental irritants induce hypertrophy of mucous glands in the trachea and bronchi, as well as an increase in mucin-secreting goblet cells in the epithelial surfaces of smaller bronchi and bronchioles. These irritants also cause inflammation marked by the infiltration of macrophages, neutrophils, and lymphocytes. In contrast with asthma, eosinophils are not seen in chronic bronchitis, whereas the defining mucus secretion is primarily a reflection of involvement of large bronchi. The airflow obstruction in chronic bronchitis results from small airway disease induced by mucus plugging of the bronchiolar lumen, inflammation and bronchiolar wall fibrosis, and coexistent emphysema. In general, while small airway disease is an important component of early mild airflow obstruction, chronic bronchitis with significant airflow obstruction almost always is complicated by emphysema. It is postulated that many of the effects of environmental irritants or respiratory epithelium are mediated by local release of cytokines such as interleukin-13 from T cells and innate lymphoid cells. The transcription of the mucin gene in bronchial epithelium and the production of neutrophil elastase are increased as a consequence of exposure to tobacco smoke. Microbial infection often is present but has a secondary role, chiefly by maintaining inflammation and exacerbating symptoms. As seen in gross specimens, the mucosal lining of the larger airways usually is hyperemic and swollen by edema fluid and is covered by a layer of mucinous or mucopurulent secretions. The smaller bronchi and bronchioles also may be filled with secretions. The diagnostic feature of chronic bronchitis in the trachea and larger bronchi is enlargement of the mucus-secreting glands. The magnitude of the increase in size is assessed by the ratio of the thickness of the submucosal gland layer to that of the bronchial wall. Variable numbers of inflammatory cells, largely lymphocytes and macrophages, but sometimes also admixed neutrophils, are frequently seen in the bronchial mucosa. Chronic bronchiolitis, a small airway disease characterized by goblet cell metaplasia, mucus plugging, inflammation, and fibrosis, also is seen. In severe cases, there may be complete obliteration of the lumen as a consequence of fibrosis, bronchiolitis obliterans. It is the submucosal fibrosis that leads to luminal narrowing and airway obstruction. Emphysematous changes often coexist. Interstitial pneumonia refers to a pulmonary disorder of unknown etiology that is characterized by patchy progressive bilateral interstitial fibrosis. The interstitial fibrosis that characterizes idiopathic pulmonary fibrosis is believed to result from repeated injury and defective repair of alveolar epithelium, often in a genetically predisposed individual. The cause of the injury is obscure, and a variety of sources have been proposed, including chronic gastroesophageal reflux. However, only a small fraction of individuals suffering from reflux or exposed to other proposed environmental triggers develop idiopathic pulmonary fibrosis. Therefore, other factors must have a predominant role. The clearest etiologic clues come from genetic studies. Germline mutations leading to loss of telomerase are associated with increased risk, suggesting that cellular senescence contributes to a profibrotic phenotype. The link to cellular aging also is in line with the observation that idiopathic pulmonary fibrosis is a disorder of older adults, rarely occurring before the age of 55 years. Other genetic associations also point to the primary defect residing in epithelial cells. Specifically, approximately 35% of affected individuals have a genetic variant in the MUC5B gene that alters the production of mucin, while a smaller number of affected patients have germline mutations in surfactant genes. These genes are only expressed in lung epithelial cells, indicating that epithelial cell abnormalities can be primary initiators of idiopathic pulmonary fibrosis. It is hypothesized that abnormal epithelial repair at the sites of chronic injury and inflammation gives rise to exuberant fibroblastic or myofibroblastic proliferation, leading to the characteristic fibroblastic foci. Although the mechanism of fibrosis are incompetently understood, recent data point to excessive activation of prefibrotic factors such as TGF-beta. Grossly, the pleural surfaces of the lung are cobblestoned due to retraction of scars and along the intralobular septum. The cut surface shows firm, rubbery white areas of fibrosis, which occurs preferentially within the lower lobe, the subpleural, pleural regions, and along the interlobular septum. Histologically, the hallmark is patchy interstitial fibrosis, on the picture shown by the yellow arrows, which varies in intensity and worsens with time. The earliest lesions demonstrate exuberant fibroblastic proliferation, fibroblastic foci, shown by black arrows. Over time, these areas become more collagenous and less cellular. Quite typical is the existence of both early and late lesions. The dense fibrosis causes collapse of alveolar walls and formation of cystic spaces lined by hyperplastic type 2 pneumocytes or bronchiolar epithelium, also known as honeycomb fibrosis. The interstitial inflammation usually is patchy and consists of an alveolar septal infiltrate of mostly lymphocytes and occasional plasma cells, mast cells, and eosinophils. Secondary pulmonary hypertensive changes are often present. These changes include intimal fibrosis and medial thickening of pulmonary arteries. Idiopathic pulmonary fibrosis usually presents with the gradual onset of non-productive cause and progressive dyspnea. On physical examination, most patients have characteristic dry or Velcro-like crackles during inspiration. Cyanosis, cor pulmonale, and peripheral edema may develop in later stages of the disease. The characteristic clinical and radiological findings often are diagnostic. Anti-inflammatory therapies have proven to be of little use, in line with the idea that inflammation is of secondary pathogenic importance. By contrast, antifibrotic therapies such as nintedanib, a tyrosine kinase inhibitor, and pirfenidone, an inhibitor of TGF-beta, have produced positive outcomes in clinical trials and are now approved for use in patients with idiopathic pulmonary fibrosis. The overall prognosis remains poor, however, survival is only 3 to 5 years, and lung transplantation is the only definitive treatment. Chronic tubular interstitial nephritis refers to a group of inflammatory kidney diseases that primarily involve the interstitium and tubules. Chronic pyelonephritis is a clinical pathologic entity in which interstitial inflammation and scarring of the renal parenchyma are associated with grossly visible scarring and deformity of the pelvic calyceal system in patients with a history of urinary tract infection. Chronic pyelonephritis is an important cause of chronic kidney disease. It can be divided into two forms: chronic obstructive pyelonephritis and chronic reflux-associated pyelonephritis. As noted, obstruction predisposes the kidney to infection. Recurrent infections superimposed on diffuse or localized obstructive lesions lead to recurrent bouts of renal inflammation and scarring, which eventually cause chronic pyelonephritis. The disease can be bilateral, as with congenital anomalies of the urethra, for example, in cases of posterior urethral valves, or unilateral, such as occurs with calculi and unilateral obstructive lesions of ureter. Chronic reflux-associated pyelonephritis is the most common cause of chronic pyelonephritis. It results from superimposition of a urinary tract infection on congenital vesicoureteral reflux and intrarenal reflux. On the left picture, you see different grades and degree of reflux nephropathy. Ureter only, reflux into ureter, pelvis, and calyces with no dilation and with normal calyceal fornices, mild or moderate dilation and tortuosity of the ureter and mild or moderate dilation of the pelvis, no or slight blunting of the fornices, moderate dilation and tortuosity of the ureter, and moderate dilation of the pelvis and calyces, complete obliterations of the pelvis and calyces, complete obliteration of the sharp angles of the fornices by maintenance of the papillary impressions in the majority of the calyces, and finally, gross dilation and tortuosity of the ureter, pelvis, and calyces. The papillary impressions are no longer visible in the majority of calyces. On the right picture, you see cystourethrogram and grade 5 vesicoureteral reflux with intrarenal reflux into several renal lobes in an infant. Both the reflux and the attendant renal damage may be unilateral or bilateral, and bilateral potentially leading to chronic renal insufficiency. One or both kidneys may be involved, either diffusely or in patches. Even when involvement is bilateral, the kidneys are not equally damaged and therefore not equally contracted. This uneven scarring is useful in differentiating chronic pyelonephritis from the more symmetrically contracted kidneys associated with vascular sclerosis. The hallmark of chronic pyelonephritis is scarring involving the pelvis and calyces, or both, leading to papillary blunting and marked calyceal deformities shown on the left picture. The microscopic changes are largely nonspecific, and similar alterations may be seen with other chronic tubular interstitial disorders such as analgesic nephropathy. The parenchyma shows the following features: uneven interstitial fibrosis and inflammatory infiltrate of lymphocytes, plasma cells, and occasionally neutrophils, dilation or contraction of tubules with atrophy of the epithelial lining. Many of the dilated tubules contain pink to blue casts, known as colloid casts, that suggest the appearance of thyroid tissue, hence the descriptive term thyroidization. Chronic inflammatory cell infiltration and fibrosis involving the calyceal mucosa and valve. Atherosclerosis may be caused by associated hypertension. Glomerulosclerosis usually develops as a secondary process caused by the loss of nephron, shown by the stem. Many patients with chronic pyelonephritis come to medical attention relatively late in the course of the disease because of the gradual onset of renal insufficiency or because signs of kidney disease are noticed on routine laboratory tests. In other cases, the renal disease is heralded by the development of hypertension. The radiologic image is characteristic. Affected kidneys are systemically contracted with some degree of blunting and deformity of the calyceal system, known as cholelectasis. The presence or absence of significant bacteriuria is not particularly helpful, as its absence does not rule out chronic pyelonephritis. If the disease is bilateral and progressive, tubular dysfunction leads to an inability to concentrate the urine, manifested by polyuria and nocturia. Some individuals with chronic pyelonephritis or reflux nephropathy ultimately develop secondary glomerulosclerosis associated with proteinuria, and eventually these injuries contribute to progressive chronic kidney disease. We will continue discussion of chronic inflammation during the next lecture.